the screen. Yeah. So thank you very much for giving this opportunity. And today I will be speaking about research and different area where research can be done in basic and applied science, focusing on sports medicine. And I am Dr. Hanjabam Barun Sharma, sports and exercise medicine specialist, as well as medical and clinical physiologist. I am from Department of Physiology, IMS BHU Varanasi, and I am currently the president of Indian Society of Sports and Exercise Medicine. Let's begin the talk. So let's define about sports medicine, because if you want to do research in sports medicine or related field, then you have to know what are the different components of sports medicine under which we can do research. This is also important because there's a widespread misconception or misnomer among the general public, also among the doctor, that sports medicine deals only about treatment of injury. It is not so. Treatment of injury treatment is one of the component of sports medicine, but sports medicine has a huge dimension, huge multi-dimension, multi-specialty, multi-component part. So here, sports medicine is generally used by the term, and sports and exercise medicine is very common. It has been renamed in different countries, out there, developed countries also, focusing on the different multi-dimensional nature of the sports medicine. So sports medicine is basically, sports and exercise medicine is basically a combination of all the scientific stuff which relate with sports and exercise and human performance science. Sports exercise and human performance science, also combined with all the medical, clinical, and allied health science. So there is a combination and interaction between these different broad scientific basis, and there are many sub branches of knowledge of the sub branches of medical as well as for performance science. Their competency, knowledge, information is required for for to do a good practice in sports and exercise medicine. It may be musculoskeletal medicine, including the surgical part, the rehabilitation part. It may be general, specific, or emergency medicine, or it may be medical and clinical physiologists and all that stuff. And sports medicine and sports and exercise medicine can be broadly divided into two components. One is sports medicine, as we know, and the basis of sports medicine is formed by performance related sports and exercise physiology, which ultimate aim is optimization of the performance, that is maximization of the dope free performance with minimization of the injury and illness. That is the basic aim for sports medicine. Whereas exercise medicine, the basis is formed by clinical exercise physiology, where physical activity exercise can be used as a therapeutic model for different non-communicable diseases, for different disease of lifestyle, or different acute as well as chronic diseases, for rehabilitation, all that stuff. And there is therapeutic use of the exercise and physical activity, as well as use of exercise and physical activity for health promotion, maintenance, promotion of the health and fitness. So all these the component, they come together to form sports and exercise medicine. So if we want to name of the different component which has been given by different authors regarding what are the different component of sports medicine, like I have already spoken all this thing, but in detail, one can say that sports medicine component is basically consisted of what you call sports and exercise related medical issues and injuries, as well as return to play decision making. That is, you have to deal with comprehensive medical care of the athlete. It may be light athlete, it may be any exercising active individual, and the sports medicine doctor has to cater to all the medical issues, as well as the musculoskeletal injuries and other type of the injuries, and they have to decide upon on what may be the different criteria for to in order to make a particular person fit for return to play or return to sports. Another component is the sports enhancement, performance enhancement by training, nutrition, psychology, and different type of concept. All this comes under sports medicine. And another one is the sports pharmacology and anti-doping and substance abuse and other ethical issues, just like you have to think whether you want to treat the particular player as a personal physician point of view, where health is the ultimate importance, or a team physician concept, where you have to think with all the team dynamics and all the what the coaches and what the manager has to say regarding the performance, also health and performance, you have to balance and all that stuff. But ultimately health should always be the top basis for making any kind of decision. The team and medical event care also comes under sports and exercise medicine, which may include the what you call PPPE, that is a pre-participation physical examination, emergency sports and exercise medicine, as well as team travel, that is traveling with team for for competition, for championship held in different countries, all that jet lag and all that concept, all this comes under sports medicine, as well as physical activity and medical care in challenging environment or the situation of the altered physiology. That means extreme, it may be extreme high altitude, it may be depth, or it may be any kind of the extreme environment. That is also important for sports and exercise medicine specialists. And another point for sports and exercise medicine is the importance of sports and exercise in specific group or subgroups or subpopulation. It may be, for example, say a pregnant athlete, it may be master athlete, it may be para uh, athlete, or it may be a juvenile, or what you call the adolescents, or players. So you have to deal with the different subsections of the, it may be physiological subsections, or it may be pathological subsections, and you have to deal because the requirement, the clinical requirements, the performance requirement, the physiological demand, demand of the game, each different for different subpopulation. That's why the sports medicine doctor has to know all these things. Physical activity and health, including exercise prescription for health and fitness, as well as for different chronic diseases, like I have already mentioned, which come under the component of the exercise medicine. So all this component, all this domain of the sports medicine is there. So sports medicine is not restricted only to treatment of special type of the musculoskeletal injury or special type of the operative management, but sports medicine comprise of all these different component, not only treatment of the injury, not only for rehabilitation of the injury, but also for the performance optimizations, the doping and all that stuff. So sports medicine, the background knowledge of all the different subsection or subspecialty of sports exercise in human performance science, including sports and exercise physiology and all this stuff, is extremely important, as well as different component of the medical, clinical, and allied health science is extremely important, like clinical physiology or orthopedic medicine, as well as surgery and PMR. All these things is extremely important. So let's go ahead with the slide. The most important point as far as sports medicine is concerned, which I've already focused, is the optimization of the performance, dope-free performance with minimization of the injury and illness. So what one has to do in order to increase the performance, you have to follow the principle of the exercise training. One has to know the principle of the exercise training, and among the different principle of exercise training, like it has to be specific, it has to be progressive to overload, it has to be reversible, time variability or periodization concept is also there, individualized concept is also there. One has to do the training in a progressively overload fashion, because if you don't do progressively overload fashion, then what will happen? Optimal physiological adaptation may not be there. If the particular person is not progressively overload, then what will happen? His or her performance may plateau or may decrease also. So one has to follow this progressive overload principle. But one point one has to remember, that this progressive overload principle should be taken within a physiological limit. I mean, your system can be challenged a little bit ahead of the physiological loading, that is extra physiological, but it has to be accompanied with sufficient rest and recovery, so that physiological super compensation, the adaptation happens. Otherwise, what will happen? Injury, illness, and chronic problem, chronic musculoskeletal injuries, or chronic the other problem, like for example overtraining syndrome or non-functional overreaching, all these things can happen. So that's why one has to one has to remember this thing, because undertraining will cause a sub performance, and overtraining will cause injury and illness. So one has to decide, a thin line is required. One should not cross to overtraining, but it should not be undertraining also. So one has to decide what is the optimum load, optimum training load, the which which the coach has to give to the player. And sports medical as well as scientific input is very important, because undertraining, if you do undertraining, then physiological adaptation, positive adaptation will not happen. What we require is the acute overload as well as up to the reaching of the overreaching phase, functional overreaching. But we want to stop that training from going beyond to non-functional overreaching, and ultimately into the overtraining syndrome. That's why we have to decide that particular training zone. And And as you already know that different authors has different authors has given their how much is too much and what should be the training of training load, so that we optimize the performance, whereas the decreased injury and illness. Like for example, this author has given beautifully given about a ratio of the acute chronic workload ratio, where a ratio of the acute chronic ratio of around zero point 0.8 to 1.3, that is the acute workload has to be relatively same with the chronic workload. In such condition, then they call it as a sweet spot where injury risk is decreased. And if you give the acute workload more than 1.5 more than your chronic workload, or the ratio of the acute chronic work ratio is more than 1.5, then what will happen? The danger, it is known as danger zone, or injury risk is there. So one has to understand how much load can be given. Similarly, if we already know that there is the extreme exercise hypothesis is also, if you give lots of heavy load of heavy volume of exercise training, then beneficial of the effect of the exercise may not be there, depending upon a different individual baseline physiological condition of that particular individual. That's why one has to be very very careful, especially when the performance, when the traditional all outdated thinking is there, that you have to give training, then only your performance will be increased. So there is no linear relationship between the amount of the training as well as for performance. It reaches a particular point, then if you give lots of training, what will happen? Performance will actually decrease because of the overtraining problem. So this one has to understand, and we have to stay between that particular optimum training zone. And and this is the current in this graph you can see that this is the current guideline of the general population, not for player, for general population, for different guideline has been prescribed by WHO and all that, the organization for the minimum exercise requirement for optimum health. Like for example, for adult, 150 minute of moderate intensity exercise, per week is generally prescribed, or moderate to high intensity exercise, resistant exercise, at least twice a week or so, is prescribed depending upon a requirement. Like 75 minute of vigorous intensity of aerobic exercise can be done. So all these things is required, but one thing one has to know, that you can keep on increasing that particular exercise load which is prescribed by the WHO, because they are well below the point where there is the hypothetical the exercise risk is there. So one is very safe if you talk about exercise prescription for general population. But for an athlete who are already being highly trained, and if the coaches, or if any they do not follow the scientific guideline, the traditional thinking is you keep on increasing the load so that performance keep on increasing. So this does not happen. That's why you have to avoid giving too much too soon, and adequate time has to be given. And hence the importance of the monitoring is absolutely important. Monitoring is very important, because if you want to stay in that particular zone, monitoring is absolutely important. And monitoring and as well as this what you call the decrease in injury and illness, whereas optimization of performance is generally done by following the principle of the periodization. So this is the periodization of the different volume, intensity, or technique training can be vary depending upon which phase of training your player is. Like it may be preparatory phase, transition competition, or second transition phase. So depending upon which phase is your player is at, you can vary the intensity, volume, and training, so that monotonicity is there. Over chronic same type of a training without any variation should not be there. Otherwise overuse injury, all these things is there. And micro mesocycle and daily fluctuation is also given. But one thing is also very important is you have to understand different moderators. Like these are the moderators which basically influence the relationship between the load which you are giving to the player and the injury and illness, because even if the person is even if you are giving a lot of load to a particular person, some person may have a very high risk of injury, or some person, even though having high risk of injury, they may not injure themselves also. So there the relationship between load and injury or illness is influenced by the different moderator. Like for example, fitness, positive physiological adaptation, and other modifiable and non-modifiable risk factor like age and all that stuff is required. So the relationship between the load and injury is not simple as as can be predicted easily. But what is more important is the monitoring of this moderator. Why? Because the moderator, they are the actual influencer which influence the relationship between internal and external load with injury. So if you modify this different thing, which are the modified like for example fitness or positive physiological adaptation, by giving a what you call an optimum ratio of the load and recovery. So by maintaining by influencing all this moderator, we can easily modify this relationship. We can increase the load, whereas we can by getting less injury and illness. This is important. So a monitoring system of this moderator, different moderator, is absolutely important, is a very good potential area of research. And different publication has already been done, but it is lacking in our country. Because just like any kind of the injury surveillance, or just like any kind of the problem, because the problem is the outcome, and the input is the internal load. Because many a times internal load is decided by the different the coaches and the different in consulting with scientific team. But this internal load can be modified depending upon a different moderator, and we can in fact design different type of the exercise intervention or different type of physiological intervention which can actually modify this moderator. Like we can increase the fitness, if we know the baseline fitness, if we know the changes in the fitness, different component of fitness, then we can easily design such that the risk of the injury or illness is decreased. So this is a very important topic which one has to focus, especially in our country, where we are having a huge population, but our international performance may not be that much. It is slowly increasing positively. Within few years, our international sporting performance is becoming very nice, very excellent. But still, so much we have to go, and we can do it by just incorporating this some of this scientific principle. So so that's why there has to be a mutual the interactive positive interaction and close working of sports and exercise medicine, as well as sports and exercise science, and with sports coaching science. So this three has to come up: sports medicine doctors, sports and exercise medicine specialists, sports and exercise medicine scientists, as well as the coaches. They all has to come as a team, and they have to work in a what you call integrated performance and health management and coaching model, so that we enhance the performance, which should be dope free performance enhancement should be done with the injury and illness free. So this is the ultimate aim of sports medicine, which one has to understand. So in order to work on the different moderator, one has to know the different component of the physical fitness, because each component has a separate requirement, separate exercise intervention, separate exercise design, or separate physiological intervention. And each component, maybe one player may be lacking in another component, one player may be high in a different component. So the component of the physical fitness is very important. Like for example, health related component, it may be cardiorespiratory endurance, it may be body composition, it may be muscular strength, endurance, and flexibility. So this is important. Another one which is important is also skill related, especially for players. Like it may be agility, coordination, balance, power, reaction, time, and speed. All this component one has to understand, and one can monitor all these different component, and we can design a particular intervention if one component is lacking. So this is important. Like for example, muscular strength, we can focus. A skill related part, we can focus. Cardiorespiratory endurance, we can focus. This is the endurance also, like balance, flexibility, coordination, and sport specific different type of speed, and all these things we can focus depending upon the requirement of that particular person. So let us talk a little bit about the cardiorespiratory endurance, because the time which is given to me is relatively very less. That's why I am talking only the basic part. So here, for example, cardiorespiratory endurance or the aerobic endurance is extremely important. Like here, you can see that in this graph, in the y-axis there is a relative risk of the injury, and x-axis is the maximum aerobic speed. And you can see that the minimum relative risk of injury when is where on the left side of the this y-axis, sorry, x-axis, where the maximum aerobic speed is around 5.1 to 5.6, and when it is decreases, like for example 4.1 to 4.4, then the risk of injury it increases. That's why the aerobic component in the form maximum aerobic speed is an important modifier, important moderator, which one has to focus in order to decrease the risk of injury. And in this component, realizing the importance of the aerobic fitness, we have published different papers earlier. Like for example, in this paper we have published in hockey player in 2017, 2016, 2016, and this is also in what you call 2016. We have published, like for example, gender difference between aerobic capacity and contribution by body composition, hemoglobin concern in young Indian national hockey players. We have published different data in this regard. Similarly, for what you call the aerobic endurance, like for example, the people are following the traditional, LSD, long slow distance, or moderate intensity, moderate intensity continuous exercise. And also some are following the intermittent type of the exercise, like high intensity interval training and all this stuff. And one particular question which is asked is regarding the different, the pattern of the foot strike, or whether you are doing the barefoot running, or whether you are using the traditional shoes, or whether you are using the what you call minimalistic shoes, depending upon that different injury profile are also there. Like for example, you can see that if a particular person is this is a non-rear foot strike, that is when the player touch the ground, his mid foot or the front foot touch the ground, that is it is the non-rear foot, whereas this is the typical example of the rear foot strike, where the heel or heel strike, where it is strike the ground like that. And you can see that this impact small if you see the vertical ground reaction force in the in the y-axis and in the x-axis, this is the percentage. You can see that there is a peak impact peak, this point is there, which is present in case of the rear foot strike, but it is not present in case of the force foot strike. And although the peak is higher in case of the forefoot, so different author has argued that different proponent of the barefoot running or forefoot running, they argue that because of this impact peak, which is you can see in the rear foot strike, the different injury can happen. So depending upon that, running form or running intensity is important. Why? Because vertical ground reaction, if you're running at a speed of say 7.2 kilometer per hour, then the load which you are getting in your lower limb and all this stuff is around 1.5 times of your body weight. And if you are running as a very high speed regarding the 25.2 kilometer per hour, then 3 times of your body weight you are getting the load. And similarly, for example, in case of the walking, if you're running, then it may be the your running may be around say what you call 2 times of that of the walking. So that's why high load is being subjected to your joint and different musculoskeletal structure, and that's why injury risks may be there. And depending upon that, you can prescribe or you can you can work out your research plan on different type of the biomechanical analysis of the technique as well as the foot running. Like for example, this author has see that you can see in this graph, this is the percentage of the injured player, and this is the black one is the rear foot strike, and a gray one, lighter gray, is the non-rear foot strike. And you can see that as far as knee injury is concerned, then rear foot strike, they are getting high knee injury, and you can see that for here low back pain and all this stuff, and rear foot strike are also getting relatively high. But if you see the foot injury, like for example metatarsalgia, or it may be Achilles tendinopathy, all this thing may be higher in case of the non-rear foot strike. So all this the study is important, and depending upon a different study, you can find out the research can be planned so that different adequate what you call the advice we can give to the coaches as well as the player. And in the similar study, but they have found some of the people, they have found that the economy for they are relatively same, or it may be a little bit higher in case of the what you call minimalistic shoe running, or in case of the of a forefoot running and all this stuff. So controversy is there, but the different published literature are also there supporting which type of the running pattern has to be followed by which player, or history, the player with a history of particular musculoskeletal injury. So this area is an important area for further research. Another important component of physical fitness is the muscular fitness as well as anaerobic fitness. Like for example, you can see that in this graph, this is the y-axis, the relative risk of injury, and x-axis is the relative lower body strength. And you can see that as the strength is higher, that is on the left side of the graph, you can see that the relative risk of the injury is very, very less. If your lower body strength decreases, like it may be say 1 to 1.7, in that case the relative risk injury may be higher. And another author, they have also see that the training, like for example strength training is absolutely important, because strength training is known to decrease the injury rate. Like for example 69% decrease in injury risk was observed for strength training as compared to say stretching. If you do stretching, especially for say what you call isometric stretching, or what do you call the non-dynamic stretching, that is if you stretch and hold for a longer time, non-dynamic stretching, then they may not be preferable for immediately for doing a particular power based exercise, and all that stuff is also reported, as well as the stretching has not been associated with much injury prevention. Like for example here you can see so strength training is important. So muscular fitness component, different type of the muscular fitness component, the monitoring is absolutely important. This one has to understand. And depending upon a different anaerobic and muscular fitness, we have tried to publish different papers in this field. Like for example here we have published in 2014, in 2015 also, in 2000 these are the different paper. This paper we have published in 2015, like gender difference in fatigue index, and their physio-anthropometric correlate for strength and flexibility in young hockey players. This we have published in what you call 2017. And in 2018 HL we have published in Journal of Strength and Conditioning, like for 6 week of sprint strength and agility training, what is the effect on body composition, cardiovascular, physiological parameter of male field hockey players. All these things we have published, and this is an important area which further work can be done. Another component, just continuing the same thing, like for example Wingate test is the classic example for estimation of the what anaerobic fitness and anaerobic power output. And Wingate test is generally used, or you can use the what you call anaerobic test like RAST, that is running associated sprint test, all this thing. Or it may be vertical jump is also important. It measures the explosive power, and vertical jump and muscle strength and all that stuff, it has been identified not only related with the performance of the player, but also for any kind of the positive health, that is all cause mortality as well as all cause morbidity. As far as that is also concerned, the strength and power, muscular strength power is also important. And similarly in this area we try to publish different paper here. Like for example you can see that we try to find out the anthropometric basis of vertical jump test in national players. We have done in cyclists and hockey players. We also have done this paper in what you call 2014. Similarly, ball hitting speed with the different anthropometric characteristics in 2014. And regarding flexibility also, like static stretching, dynamic stretching, we have published a booklet there when I was working as a sports medicine specialist in SAI in NERC Imphal. This was the compilation we have done. It was a compilation on flexibility and stretching. What type of stretching you can do? One can do what you call PNF stretching, that is neuromuscular facilitation type of the stretching. It may be ballistic stretching, it may be dynamic stretching, it may be static stretching. So depending upon what type of stretching can be done, or do stretching has to be done always before the any kind of the exercise, or whether the stretching is more beneficial if you do what you call dynamic stretching, especially after the after your performance, or after your competition, or after your exercise. All this thing we have talk about in this book. So going ahead with the next one, this is basically for just measurement of the different strength, like for example isometric strength, isokinetic strength, or concentric strength. A heavy machine, this is the isokinetic variable resistance dynamometer. isokinetic dynamometer, where your lower limb, you can calculate the what you call the isometric, isotonic, or isokinetic strength ratio you can calculate between, say, hamstring and quadricep, which are important, which are known to important for different injury risks. But the problem is this instrument is a little bit costly, bulky, and may not be available to everyone. And this is the custom made which we have designed and we have applied patent for. This is a simplified custom design instrument where, and this is the isometric dynamometer. It is connected to the analyzer, and this is we also use the EMG electrode in order to find out the relationship between the muscle force production and the EMG, the activity, and depending upon a different angle of the joint, we can calculate the strength curve. And strength curve is an important parameter. Like similarly, this instrument can be modify to find out the strength curve of, say, what you call knee flexion or knee extension instead of elbow flexion and extension. This one can easily do, and these are very much important for angle specific rehabilitation or angle specific training. Like for example, variable the training one can do. So this is the, we have already filed a patent, and it was the file on 7 September 2020. And we have also, after filing the patent, we have also published few papers, one papers in this regard. And this simplified experiment to find out the angle dependency of the isometric strength in the form of the strength curve, it has been included as a practical for MBBS, as well as postgraduate who are doing post graduation in medical physiology at AIMS New Delhi, All India Institute of Medical Science. It has been officially accepted as one of the physiological practical there. And another one which is also important is regarding the different type of the newly modified training based upon different physiological modification. Like for example, BFR training, blood flow restriction training. Because see, what is happening is resistance training is very important, because the muscle strength and muscle power and maintenance of the body composition is absolutely important for performance as well as for health. But the problem is, if a particular player suffer a joint problem, joint pain or joint injury or muscular injury, or you are dealing with a master athlete, or you are prescribing exercise to a elderly population, or any kind of the condition where he or she is not able to do exercise at a relatively higher intensity, which is required for your muscle hypertrophy, then you have to modify the training, because muscle hypertrophy depends upon three things. One is what? The mechanical tension developed by your rest and exercise. Another is the physiological micro tear. Different micro tear processing is there, that when the micro tear heals, then muscle hypertrophy happens. Another is the metabolic stress, the metabolic load. And this metabolic load you can create by just using the concept of the blood flow restriction training, where you restrict the venous outflow from that exercising area, but not the arterial inflow. You are restricting only the venous outflow. The venous outflow by using a tourniquet or different band, and you can do exercise at a very relatively lower load, and you will be able to achieve relatively similar muscle hypertrophy. At least you will be able to say prevent the muscle atrophy. Like for example, in this paper, they have studied for the players or for the person who are having ACL reconstruction after their ACL rupture. So they were, after post ACL reconstruction, knee immobilization was done in brace, and these are the different group. Experimental group is where BFR was given. They have not given any kind of exercise, even without giving any kind of exercise intervention. Just by using the passive BFR, then you can see that the decrease in the cross sectional area was much less in the experimental group as compared to the control group. That means the atrophy, muscle atrophy or muscle wasting after the post-operative the condition may be minimized just by using this BFR concept. But this is a new area of research, and many interesting research are going on, and one can do research in this field also. Like for example, here you can see this is the total cross-sectional area reduction, statistical significant reduction was there. This is the extensor, knee extensor, like what quadricep and all this. So this is a knee flexor, hamstring side. So BFR without exercise, even without exercise also you can do, and BFR can also be given not only for isotonic rest and exercise, it can be given for aerobic exercise also, like cycling, running and all this thing, or it can be used for the isometric hold. So this is important. And knowing the increasing demand and the increasing utility of this interesting topic, we have conducted a session in the previously conducted our ISSEM, that is first international conference of Indian Society of Sports and Exercise Medicine, on 24 to 26 March 2022. This is the concept we have given, and here what we are we are doing by using a vascular Doppler ultrasound, portable vascular Doppler ultrasound. We are calculating the different what you call the limb occlusion, limb arterial occlusion pressure. It can be calculated here in brachial artery. Ideally it should be done at the radial artery, what you call here, not in the brachial artery. You can do in a brachial artery also, no problem. Here, like in this picture, it can be done in a radial artery, and depending upon the percentage of the total arterial occlusion, you can prescribe the intensity, or the intensity or the pressure at which you have to maintain that what you call the band, so that the venous outflow occlusion is there without restricting the arterial occlusion. Another important point after knowing all this physical fitness component is regarding different electrophysiological, neurophysiological, as well as biochemical monitoring device. By using all these device, one can monitor the different modifier, because the modifier is very important, because they are this modifier are the one which influence actually the relationship between load and injury. So if you are able to monitor that modifier, then at least you can prescribe to the coach. It will very helpful the coach as well as the player, so that they can increase or decrease the training load depending on their that status. Like for example, HRV, heart rate variability training with the training load, you can see in this graph, like training load is measured in meters cover at rest intensity. This is the HRA at the there is a natural logarithm RMMSD. Here you can see this is the baseline, there is week 1, and this is the overload, where overloading, training overloading is done. And here you can see that the HRV, the relationship between the HRV and all these things. Like for example, HRV decreases in case of the overload, and HRV increases in case of the tapering condition. The tapering is a condition where you decrease the training load. We decrease the training load to a particular intensity such that we maintain that particular performance, but not below a particular threshold, because if you decrease that particular threshold, then effect of detraining will happen. So we don't want to get the detraining, but we want to get in the tapering, especially then before the competition or so, where you reduce the training load, and this is indicated by HRV. So if you do HRV monitoring, continuous HRV monitoring of the player, then subsequently you can indirectly predict whether your training load is becoming high or not, and hence you can indirectly focus on different effect, like for example, whether the player is going into the side of the overtraining or not, overuse injury may be there or not, like this thing. So similarly, realizing this importance, we have what you call conducted a workshop on cardio autonomic and HRV. The topic, it was done in similarly ISSEM 2022. Similarly, for a concussion player also, concussion is also very common. Concussion, mild traumatic, minor traumatic, brain injury. And in concussion, you can use different, neuro electrophysiological parameter, like you can use the EMG, EEG. You can use the EEG, or you can use a different what you call a biomarker for different concussion, because biomarker dependent concussion is there. Even though the concussed person may be clinically normal, but their neurophysiological, neurobiochemical parameter at the level of the microscopic or cellular level may not be there, because second impact is very important. If you as a sports medicine doctor, doctor, if you certified a particular player that you are fit to play again, then what will happen if the previous concussion is not healed? Then second impact may be there, and then second injury, second concussion, second episode may be more dangerous than the first one. So the cumulative effect is there, so one has to be very careful. Like for example, if you see, this is the month, even after say what you call the 30 months and all, this is the baseline, this is the control group where the person is not concussion, and this is the person who are having concuss, and days after concuss, it may takes about 30 days also, or it may take beyond also, in order to reach the comparable to the control players or control person. So different biochemical neurochemical markers are there. Like for example, this is, they have used what you call the ratio of the n, and there is n acetyl aspartate to creatine. So this is the study which was done using the proton magnetic resonance spectroscopic study. So this kind of study is also important. Concussion, counter coup, and coup injury, it is very common. Concussion is one of the most common. It may be very common among the contact sports. It may be football, hockey, martial art, all these things. And physiological and biochemical monitoring is absolutely important. And sleep is also important. Sleep is one of the most neglected area, but sleep has extremely important role, and one has to understand. Like for example, in this paper you can see that the likelihood of the injury was reduced if the particular player sleep around 9 hours. So, and it increased, the likelihood of injury increased around to if you sleep around 5 to 6 hours. So ideally one should sleep around 8 hours, at least 7 hours, and you can progress to 8, and if required even up to 9 hours also. Like for example, the athlete who have slept on an average of less than 8 hours, they have per night were 1.7 times more likely to have had an injury as compared to the athlete who have slept equal to a more than 8 hours. So sleep is very important. Similarly, in 2021 also, this author has also reported, like sleeping equal to or more than 8 hours per night increases mood, energy level, training quality, and decrease the perceived stress and the risk of the injury illness in university athletes. So this is also important. So sleep monitoring, physiological sleep monitoring is important, and an important area of research one has to focus, and we have to do different type of the data collection in this regard, because in India data regarding this is not so present. Realizing the importance, we have conducted we have written this review article. It was published just now in 2022. It is about how much one has to spend time in physical activity, sleep, and sedentary in 24 hours in order to achieve the good health. So at least 7 to 9 hours of sleep is required, and 8 hour, less than 8 hours of sedentary activity for adult, and around 150 minute of the moderate to vigorous physical activity, especially aerobic physical activity, is important. For strength training, it should be at least twice 2 days a week, or at least and by avoiding the subsequent days, like for example 3 times a day with 1 day gap, you can do strength training. Moderate to high intensity strength training can be done. So another important point, which is important area of the research, especially for Indian, is regarding the return to play in COVID-19. COVID pandemic has affected the life of the player, the training of the player, as well as all the support staff and coaches surrounding. Because see, what is important is viral infection, not only COVID but all the other viral infection. They may predispose the player to hit exhaustion. Post viral fatigue syndrome may be there. Viral myocarditis or pericarditis maybe, and we all know that around 5 to 25% of sudden cardiac death in player may be related with acute or subacute myocarditis or perimyocarditis. It may not be related with COVID, but still risk is there, even though it is a very small, but risk is always there. So one has to understand that risk is there, and since risk is there, therefore especially the sports medicine doctor has to be very careful regarding return to play certificate when one is dealing with the COVID in case of the player. and this is an important area of research. And realizing this, we have published the paper on resumption to swimming post COVID-19 lockdown in 2021. And our society, Indian Society of Sports and Exercise Medicine, have given a certain guideline. These are the basic guideline, not a rule for everyone. One has to individualize regarding the time frame of the COVID-19. For example, if a player is having unusual and unexplained alteration in activity related perceived to rating to perceived exertion, self-reported exertion, it may be box scale or modified box scale, then it may indicate a SARS-CoV-2 infection, even though he or she may be negative in case of the if one does the testing. Therefore, if alteration is there in daily perceived exertion in any time the physical activity or sports activity, then one should be very very suspicious that he or she should go and do COVID testing immediately. And asymptomatic COVID-19 positive player but asymptomatic, they should restrain from intense exercise for at least 2 weeks. At least 2 weeks they should restrain. No sports participation for symptomatic COVID-19 players. Well, Hannah, no sports participation with pneumonia. If there is no pneumonia or if there is no myocarditis, then you have to restrict sports participation for at least 2 to 4 weeks. If there is no pneumonia or myocarditis. If there is pneumonia, then it has to be at least 4 weeks. That is 1 month. Has to be there. For pericarditis and myocarditis, 3 months and 6 months. For at least 3 months for pericarditis, at least 6 months for myocarditis. This one has to understand. And for the recovered player from COVID-19 with there is no symptoms for say at least 7 to 10 days, and the time of at least say equal to or more than 10 days of the first symptom onset has elapsed, then he may do return to play. With the initial return to play can be done very very slowly, like for example minimal exertion for at least 2 weeks. Initial 2 weeks should be a minimal exertion, reaching to pre-COVID activity after 4 to 5 weeks, after at least 4 to 5 weeks. So very very slowly, gradually one has to do. And the medical evaluation and a supervision has to be done. Relevant cardiac pulmonary ergometry based or biochemical investigation should be done, including the cardiac MRI if needed, or lead gadolinium enhancement test with cardiac this thing MRI if required has to be done before, if you suspect something, before you allow a particular person for return to play. So this is a rough guideline which we have used, but the problem is there is no definite study in case of the Indian scenario, and much work has to be done in this section, and that's why I mentioned this thing as encouragement for everyone. Another point one has to understand, and since I've already talked about the role of the sports medicine not only for the players, this is a misconception. Sports medicine is not only dealing with sports elite player, but sports medicine doctors has to offer sports medicine service are also beneficial for majority of the population who are sedentary, who doesn't do any work, who are obese, who are who have diabetes, hypertension, or other non-communicable diseases. For that, sports and exercise medicine is extremely important. This is especially important in case of the India, because the India physically inactive adult, in India, it is fifth among the Southeast Asian countries, and it is above 12 countries worldwide. It was reported from WHO website. I have taken this data from WHO website. So India was fifth among the South Asian countries and above 12 countries worldwide. And India is, everybody knows that India has been classified as a what you call diabetic capital of the world, and in 2019, and also the prevalence of the hypertension is also very high in India. And so sports medicine has an important role for fight of the different physical inactivity, diabetes, obesity, obesity, because all the complication of the COVID is increased if there is a obesity is there. That's why obesity is the word which is used, just like in just like diabetes. So all non-communicable diseases, this one has to understand. And regarding this, we have published different papers here also, like for example, central obesity, like waist circumference and waist height ratio was found to be a significant risk factor for hypertension. This we have done in what you call 183 adult population. And this is also another paper in which we have see the sensitivity for by analyzing ROC curve, where whether we can use different simple anthropometric parameter for classifying random blood sugar, high and random blood sugar. Like for example, here you can see that random blood sugar equal to more than 140 milligram per deciliter. You can see that the ROC curve, the classifier, was statistical significant with a cutoff of 0.5964 for waist height ratio. Similarly, for waist circumference, which this waist height ratio, waist hip ratio, waist circumference, they basically denote the abdominal obesity. There's a visceral obesity, which is dangerous. So this is we have performed in males, n equal to 130. We have published in 2029. Similarly, even for a diabetic patient also, if you compare the diabetic this 40 males with the non-diabetic 40 healthy person of the comparable age, we have compared, and you can see that the VO2 max, that the aerobic fitness was statistically less, statistically lower in case of the diabetic. Red is the diabetic. And you can see that if you control, because see, diabetic also has higher percentage of body fat. They also has waist circumference and a waist height ratio. They also have, diabetic also has all this higher. So we don't know whether this decrease in VO2 max is because of the difference in body composition pair, because the body composition also has independent negative impact on aerobic fitness. So in for that for that thing, we want to see what is the effect of the diabetes. That is, what is whether the difference in the aerobic fitness after among the diabetes as compared to the after controlling that difference in body composition by using the statistical theory of ANCOVA. We have used the covariate as percentage body fat waist hip ratio, which were found to be statistically significant. And we can see that VO2 max was still significant. That means the significant difference between diabetes and a non-diabetic was still present in as far as aerobic fitness was concerned, even after controlling the difference in body composition. That means you have to give exercise intervention, aerobic exercise intervention, because VO2 max is associated with the risk of diabetes as well as risk of the mortality and morbidity with diabetes. So that's why, independent of the obesity parameter, the fitness is also important. Fitness parameter is also important in diabetic also. So that's why the importance of the sports and exercise medicine research is needed in this area, and in similar area working in different non-communicable disease. So coming to the end of my slide, and I just want to convey the information that the university which right now I'm attached, that is Banaras Hindu University, is excellent place where different sports activity are going on, even professional sports activity, like for example university sports university. This is the university sports board of Banaras Hindu University, and these are the different game which are the training are attached with sports university sports board. It may be archery, athletic for male and women, badminton, basketball, boxing, chess, cricket, cycling, football, gymnastic, malkham also, handball, hockey, kabaddi, kho-kho, powerlifting, weightlifting, rowing, shooting, squash, racket, or swimming, table tennis, volleyball, wrestling. All these things are there with different indoor as well as outdoor playing field of Banaras Hindu University. It's a very well developed this thing. And also we also has Banaras Hindu University also has separate training center for SAI, Sports Authority of India. They have signed a MOU with the Banaras Hindu University, and SAI training center is there inside the campus of the BHU, where regular training is going on. In the same way, the gym khana is there in Banaras Hindu University, different gym for Institute of Medical Science, Institute of Science, and IIT BHU also has various high well maintained, highly maintained sports ground. And we already know that the Banaras University has a separate department of physical education and sports science, also under faculty of arts, where different post graduation bachelor, postgraduate, as well as PhD level, postdoc work level are going on. And we also has the faculty of performing art. Performing art is also important, like for different dance, Kathak, Bharatnatyam, and all the different dance, Indian classical dance form are also separate department is different, separate faculty is there. And also apart from that, Banaras University also has a university mountaineering center, different. They train for different mountain medicine, the courses was also trained in the past. And similarly, different mountaineering, the short term courses are also going on. So all this thing is important. That's why Banaras University is an ideal place, because this is my lab also. Since joining BHU, Institute of Medical Science, I have tried to open this lab of sports exercise medicine and sciences, human performance, environmental functional medicine, lifestyle medicine. And by cooperating with different interdisciplinary, interfaculty, inter-institute uh, of BHU, including medical science, IIT BHU, where technical support, biomedical engineering, and other section of the IIT technology can be taken. And Institute of Medical Science is already institute of the faculty of the performing arts. Collaboration we can do, and also collaboration with the different what you call university sports board members, and collaboration with the what you call the athletic association of each institute or faculty, or with with the department of the physical education. So many research can be done, not only cross sectional but prospective high end research can be done at Banaras University. Thank you very much for giving this opportunity. I am Dr. Hanjabam Barun Sharma, signing out. Thank you very much.